Okay, we're going to continue where we left off last time, 18.5. So you remember I told you there's a few different circulation patterns, really. I mean, we have systemic circulation, where we talked about movement of blood through the heart and through the rest of the body, and pulmonary circulation, where we have movement of blood through the lungs to oxygenate it. But now we're going to talk about coronary circulation. So does anyone remember what I told you last time we mean by coronary circulation? Just kind of in a nutshell. We're supplying blood to the heart muscle. Okay? This is not the blood that's going through the chambers of the heart. This is the blood that we're supplying to the muscles of the heart, so the heart can work. So we're supplying nutrients to the heart, we're supplying oxygen to the heart, and we're taking waste products away from the heart. Okay, so don't confuse them. So we continuously supply the cardiac muscle, the myocardium, with oxygen and nutrients. We have left and right coronary arteries, and these come out of the ascending aorta. So you see those right here in the picture. So they are oxygenated, or the blood is oxygenated. So feel when the ventricles are relaxed during diastole. So you remember systole is contraction, diastole is relaxation. We'll get into more of that today. And myocardial blood flow can increase to 9 times the resting level during the most maximum exertion. And let's look at the different coronary arteries. The right coronary artery supplies the right atrium, parts of both of the ventricles, parts of the cardiac conducting system. It follows the coronary sulcus, which is the groove that goes between the atria and the ventricles. And it branches. The main branches are the marginal arteries that supply the right ventricle, and the posterior interventricular artery, which is the posterior descending artery. It runs in the posterior interventricular sulcus, and it supplies the interventricular septum and the adjacent parts of the ventricles. The left coronary artery supplies the left ventricle and the left atrium and the interventricular septum. The main branches are the anterior interventricular artery. This is the left anterior descending artery. It follows the anterior interventricular sulcus. It supplies the interventricular septum and the adjacent parts of the ventricles. And then we have, of the main branches of the left coronary artery, the circumflex artery. It follows the coronary sulcus to the left. It meets the branches of the right coronary artery posteriorly, marginal artery. This marginal artery is off the circumflex, which supplies the posterior of the left ventricle. So it also branches off. I mean, all of these arteries have other branches. So the marginal artery is one that comes off the circumflex. And here they are in the picture. This is the anterior view. Here's the left coronary artery. It shows the left. It shows the circumflex artery here, where it branches off, and then downward descending the anterior interventricular. On the other side, of course, the right coronary artery, which branches into the marginal arteries. Okay, here we have a posterior view. It shows the circumflex artery coming all the way around to the back, and it shows it branching off into the posterior interventricular artery. You also see the right coronary artery coming to the back. I think I was just pointing to the wrong thing, by the way. So the circumflex artery there, and the marginal artery coming off of that. And here we have the posterior interventricular artery coming around, branching off from the right coronary artery. Remember, arteries are always colored what?
Blue.
Arteries.
Oh, red.
Red.
And then blue.
Why?
Because they're opposite.
Because they're oxygenated, right? And again, blue is not really blue. It just kind of looks blue through the skin. It's just darker.
Saying there's no oxygen in the atrium.
Sorry?
There's no oxygen in the atrium.
Yes, yeah. We actually do carry. Oh,
Does that make
you're
sense?
saying in the chamber itself?
Right.
Yeah, not in the right atrium, no, because that's where deoxygenated blood comes in. Is the right atrium, right?
Okay, yeah.
Right. The left atrium, though, is the blood that comes out of the lungs
Right. Okay.
after it's been oxygenated. That's a good question. Okay. Now let's look at veins. So the veins are deoxygenated. So they're basically pulling the blood off or draining the blood off. So that's going to carry the waste and carbon dioxide. So it drains the areas that are supplied by the anterior interventricular artery. It empties into the coronary sinus posteriorly. And do you know where the coronary sinus goes into, by the way? It comes back into the heart. Okay, at the right atrium. Okay, the anterior cardiac veins, they drain the anterior surface of the right ventricle, and they empty directly into the right atrium. So we see the great cardiac vein here on the right side of this picture. And you see the anterior cardiac veins shown on the left side of this picture. Okay, the coronary sinus is an expanded vein that empties into the right atrium. Posterior vein of the left ventricle drains the area that's supplied by the circumflex artery. The middle cardiac vein drains the area supplied by the posterior interventricular artery. It empties into the coronary sinus. And small cardiac vein drains posterior of the right atrium and ventricle and empties into the coronary sinus. So you see the main coronary sinus here. You see a branch in the middle cardiac vein. You see a branch here also, the posterior vein of the left ventricle. And at the end of the coronary, or the same vein at the end of the cardiac sinus, you see the great cardiac vein. And keep in mind, looking at this picture, drainage begins at the smallest vessels. Okay, so when we're showing branching patterns of arteries, we always start larger and work our way to where it gets smaller, because that's the flow of blood, is to the smaller vessels. But flow of blood in veins goes from smaller to larger. Blood flow through the coronary circuit is maintained by changing blood pressure and elastic rebound. Elastic rebound is just when we're not contracting muscle. We don't contract, we let it rebound naturally by the natural flexibility of the fibers. The left ventricular contraction forces the blood into the aorta. It elevates blood pressure there, and that stretches the aortic walls. Then we have the left ventricular relaxation. At this point, pressure decreases. The aortic walls recoil, and that's your elastic rebound. And that pushes blood in both directions. So forward into your systemic circuit, but also backward into your coronary arteries. Let's talk about some of the valves in controlling blood flow between the heart chambers and the great vessels now. So we're moving out of coronary circulation. Each side of the heart has two chambers, as you know, an atrium that receives blood, and then we send blood to the ventricles, and that pumps blood out of the heart. The right and left atria are separated by the interatrial septum. The right and left ventricles are separated by interventricular septums. Much thicker, though, than the interatrial septa. Between each of the atria and ventricles, we have atrioventricular valves, or AV valves. It allows one-way blood flow from the atrium into the ventricles. And at the exit from each of the ventricles, we have semilunar valves. They allow one-way blood flow from the ventricles out into either the aorta or the pulmonary trunk. So we will often call those valves simply the aortic valve or pulmonary valve. It's more proper to say aortic semilunar or pulmonary semilunar. And we'll talk about the AV valves in a minute because there are other names for that, as we've mentioned before. But it's much simpler to simply call them atrioventricular valves because it makes sense, because they are between the atria and ventricles. Okay, so this picture actually does give you the other names for the valves as well. So if we look at the right AV valve, we also call that one either the right atrioventricular valve or the tricuspid. Again, that's between the right atria and the right ventricle. The valve between the left atria and left ventricle we call the left AV valve, or it has two other names, a bicuspid or a mitral. And the cuspid part has to do with how many flaps it has. The semilunar valves going to the aorta and the pulmonary trunk are similar. Okay, so this is a little bit really a summary for you from last time. We know the right atrium receives deoxygenated blood from the superior and inferior vena cava and the coronary sinus from draining the heart muscles. And remember, go and walk through the model I've got on the floor out here when you have the opportunity. The fosso valves, this is a remnant of the fetal foramen valve that allows the fetal blood to pass between the atria. It actually closes at birth, but you see some remnants of it. The left atrium receives oxygenated blood from the pulmonary veins. So remember, this is one of the exceptions where usually arteries carry oxygenated blood and veins carry deoxygenated. Well, the arteries that go to the lungs have deoxygenated blood, and the veins that come out of the lungs into the heart carry oxygenated. So that's one difference. Although it is still true that we always call things arteries that come away from the heart. So that's probably the best way to remember that. Okay, the pectinate muscles, these are muscular ridges that are located inside both of the atria, along the anterior atrial wall and in the auricles. Remember, the auricles are those coverings of the atria that you can see in those both the models as well as the actual pig heart. Okay, the right ventricle receives blood from the right atrium through the tricuspid valve. It has 3 cusps or flaps. Again, it's probably easier just to remember it's a right AV valve. And with contraction, the blood exits through the pulmonary valve, through the pulmonary semilunar valve into the pulmonary trunk. So whenever we have systole, where that ventricle contracts, the right ventricle, it sends blood into the pulmonary trunk, into the lungs. The left ventricle is much thicker wall than the right. You saw this when you cut the heart in two. It receives blood from the left atrium through the mitral valve, also called the bicuspid valve because it has 2 cusps, or easier again, the left AV valve. And with contraction, the blood exits through the aortic valve, through the aortic semilunar valve, into the ascending aorta, and then throughout the body. There's your systemic circulation. Now, inside of both of the ventricles, you see these muscular ridges we call the trabeculae carni. So let's talk a little bit more about the heart valves. The AV valve structure in particular, if we look at the tricuspid, each has 3 valves. And if we're talking about the mitral or bicuspid, it has 2. The cusps attached to tendon-like connective tissue bands, or the chordae tendineae. You saw that when you cut the heart open. They're anchored to thickened cone-shaped papillary muscles. And by the way, these chordae tendineae are what we call the heartstrings. I used to talk about things that pulled at your heartstrings. That's literally what they were talking about. The moderator band, this is a thickened muscle ridge that provides rapid conduction paths. It tenses the papillary muscles right before the ventricular contraction. And the purpose is to prevent any slamming or inversion of your AV valves, because it can cause damage, or it can just simply cause a misfunction of the valves, and it does happen. Okay, so this shows those valves again, and it shows the chordae tendineae. Again, very similar to tendon material. If we compare the chambers, they actually have similar workloads. I mean, they do have to carry the same amount of blood, so the walls are about the same thickness. But the ventricles have very different loads. The right ventricle has thinner walls. It sends blood to the adjacent lungs. It's not as hard to push it. The contraction squeezes against the left ventricle, and that forces blood out the pulmonary trunk quite efficiently. Not a lot of effort. It doesn't take a lot of pressure for that to happen. Ventricles have very different loads. Again, the left ventricle has a very thick wall around a chamber, 4 to 6 times the pressure of the right ventricle, because it's going to send blood through the entire systemic circuit. And whenever you have contractions, it decreases the diameter and the apex to base distance of the heart. It reduces the right ventricular volume, and that helps it in the emptying effect of the heart in the chambers. So if you were to have cut the heart in this type of section, you would have seen a clear difference in the atrium ventricle shape as well as the thickness. So the wall of the left ventricle is much thicker. And this picture shows the difference in dilation of the ventricles versus the contracted version. Okay, when the ventricles are relaxed, they fill up. So really, it's pretty easy to get the ventricles filled with blood. You simply have relaxed ventricles, and you have gravity helping you, right? Because they're above the ventricles, so the blood just kind of flows down pretty easily. The AV valves open. The chordae tendineae are loose. The semilunar valves are closed. And the semilunar valves going to the pulmonary trunk or to the aorta are closed when we fill up the ventricles. And the blood pressure from the pulmonary and systemic circuits pushing back on them the other direction are what are keeping them closed. And because keep in mind the semilunar valves open superiorly, right? Flow goes upward. So when flow comes the other direction, or pressure comes from the other direction, it causes those flaps to close this way. So we don't want oxygenated and deoxygenated blood to get mixed up. Okay, when the ventricles contract, though, and push, now the semilunar valves are going to open up because now they're under pressure, but the atrioventricular valves now, that would have opened in the opposite direction, now their flaps are going to be pushed closed from the ventricle side. And again, we're preventing any inversion. We don't want backflow or regurgitation. Now again, there are disorders where that happens, and we don't want it to happen. So again, the AV valves close when the ventricles contract, and the semilunar valves open. Okay, when we look at cardiac skeleton, skeleton, we see we have flexible connective tissue frame. We have interconnected bands of dense connective tissue. It encircles the heart valves. It stabilizes the position. It surrounds the base of the aorta as well and the pulmonary trunk. And another purpose in it is to electrically isolate the atria from the ventricular myocardium. Again, the way the heart contracts is extremely important. If we look at the pulmonary and aortic valves, we see each has 3 half-moon-shaped cusps. They prevent backflow of blood from the aorta and the pulmonary trunk back into the ventricles. They don't have a muscular brace. It's not needed because the cusps support each other when they are closed. So it's a little bit different than the AV valves. Now, there are some disorders, as I said, with the valves. In valvular heart disease, the valve function deteriorates until the heart can't maintain the adequate blood flow. There are congenital malformations or heart inflammation that we call carditis. In many severe cases, it could require replacement with a prosthetic valve like the one you see in this picture. And you've probably heard of getting pig valves also. I think we will stop right there and we'll talk about arteriosclerosis next time.